My name is Christopher Crane. I'm the gastrointestinal section leader in the Department of Radiation Oncology at Memorial Sloan Kettering. It's important to realize, and I always tell patients this, that back in the 2 and 3D era, not that long ago, 10 years ago, 15 years ago, patients could get extensive moist desquamation, urethritis, dysuria, and diarrhea very commonly because the treatment just wasn't focused it wasn't focused to avoid the small intestine and skin as well as it is now. IMRT has basically made a very obvious difference in the tolerability of this treatment, to where we really don't see unmanageable diarrhea very much, and the skin reaction is really confined to the anal canal. So patients routinely work through treatment, they remain active, they do not have treatment breaks, whereas in the past, before IMRT, there were routine treatment breaks, which there's certain data that would suggest, population-based data that would suggest that had a detrimental effect on tumor control. So now, when I talk to patients about what to expect, the main toxicity they're going to expect is some moist desquamation in the anal canal. It's never really severe unless they have a hemorrhoid or fissure. And when that happens, in conjunction with moist desquamation, it can be very painful and sometimes require narcotic pain medication. So if someone starts to have anal canal pain early in the course of treatment, I suspect something else going on, because I don't normally expect severe pain until the end of treatment. And even at the end of treatment, it's I'd say mild to moderate discomfort during bowel movements. The way that we manage that is typically we use a moisturizing type cream like Aquaphor until there's desquamation. And then when there's desquamation, we use a barrier cream. A lot of different creams can be used. We use Silvadene cream. When I was at MD Anderson, we used a lanolin-based cream to provide a barrier to the moist desquamation, so that it's more comforting during bowel movements. If there is a hemorrhoid that can be detected, then don't forget about something as simple as preparation H, which causes vasoconstriction and can help address that. If there's a fissure present, sometimes if you examine a patient, you can see there's a fissure, or if you do a digital rectal exam, you can feel a linear ridge within the anal canal. We use nifedipine paste, which applied to that area the best that the patient can will relax smooth muscle and bring the edges of the mucosa together and facilitate healing. This can happen if a patient has problems with constipation and things like that, but it's just always important to think about what else could be going on if there's severe pain. And I don't have any problems with giving patients narcotic pain medication. Usually short-acting alone is enough for patients towards the end of treatment, but the acute toxicities are very manageable. Patients can also get diarrhea during treatment. Usually it can be either watery diarrhea or multiple form bowel movements, both of which would be considered, by the way we describe things, as diarrhea. However, the watery diarrhea is typically small bowel enteritis, and the multiple formed bowel movements that are increasing in frequency is proctocolitis. So the difference is that the small bowel enteritis is something that is it could get someone dehydrated, but the proctocolitis is not going to do that. So usually with IMRT, we don't have much of a contribution from radiation to the small bowel enteritis problem. But mitomycin does cause unpredictable severe diarrhea that's watery, more commonly after the second dose of mitomycin. Either case, small bowel enteritis or large bowel enteritis and proctitis is just treated with Imodium. Usually people notice from either rectal cancer treatment or anal cancer treatment that they have increasing small bowel movements towards the end of treatment, and almost no patient wants to take a medication for that. They might take an occasional Imodium. It's just enough to be noticeable and slightly bothersome, but it's not a significant problem. We always, during the treatment, like to talk to patients during the weekly visits to make sure that they're having between 2 and 4 bowel movements a day. So one reason to try to keep it to a smaller number is that it's painful towards the end with each bowel movement. So another trick that you can do is have patients go onto a low fiber diet at the beginning of treatment. There's no need to start that before about 2 weeks, but a low fiber diet will provide less residual and fewer overall bowel movements. The skin creams that we use, and when there's moist desquamation in the anal canal, we use a barrier cream, usually when towards the end of treatment, and a moisturizing cream before that, before there's moist desquamation. The other thing is fatigue. We talked about with patients. With IMRT, we almost never have any dysuria that happens because we do a very good job of sparing the external genitalia.